Welcome to the Urgent Care Association's Solutions on Demand webinar brought to you by HealthTrack RX. Today we will discuss the role of rapid multiplex PCR to optimize clinical decision-making when evaluating infectious disease complaints in the outpatient setting and really focused on the heat of the summer. Change the diagnostic challenges that you'll see in your clinic during these summertime months. And to work through these cases, we're joined by two experts in molecular infectious disease diagnostics and urgent care medicine. I'm your moderator, Ben Favre. Dr. Janie French, who is a microbiologist and medical science liaison for HealthTracks. Dr. Stephen Goldberg, who is an urgent care practitioner at University of Louisville, is also the chief medical officer for HealthTrack RX. So Dr. Goldberg, your fourth case today has a chief complaint of painful lesions on the thigh and buttock area. It's a 25-year-old male who's sexually active. Based on that quick summary, anything jump out at you that you're thinking of?
When I actually had this case, and the patient came to me on follow-up after the patient and their partner had been told that they had a first episode of HSV2 or genital herpes, and that decision, that communication was based strictly on empiric evaluation of this blistering lesion. What I would begin to say is that having seen different types of blistering lesions and knowing that genital herpes or HSV2, not every time, but consistently has a genital manifestation, this patient is presenting with painful lesions on the thigh and buttocks, but did not have any genital involvement. That occurrence caused me to question the initial diagnosis of HSV2 or genital herpes.
Very interesting. Janie, the clinical exam shows it's on the left buttock area, anterior thigh, finds rash with a dermatome pattern, no genital involvement. I'm sorry, Stephen, anything to add based on that information?
Well, there were certain features. Again, Ben, the first, there wasn't genital involvement. The involvement of the buttocks wasn't necessarily helpful to help me differentiate among different types of blistering lesions. But the anterior thigh lesion following a dermatome pattern was pretty pathognomonic for a blistering type of lesion, specifically a varicella infection, a Coxsackie virus, or in an adult, it can be called shingles.
Janie, Dr. Goldberg mentioned a couple pathogens he's thinking of. What are the other pathogens to be concerned about and the thought process on these types of infections?
So a blistering lesion around the groin might suggest that sexually transmitted infections should be included in the differential. But as we see in this case, there's no genital involvement for this patient. So it's likely not a sexually transmitted infection. But there are also plenty of other non-sexually transmitted pathogens that can cause blistering lesions. As Dr. Goldberg just mentioned, varicella zoster virus, Vibrio vulnificus, enterovirus, just to name a few. And shingles tends to be more common in the spring or summer, actually typically thought to be due to increased UV exposure. This increased UV exposure reactivates the virus and leads to those painful shingles outbreaks that can be observed. But similarly, it could be non-infectious, like poison ivy, which is going to also be more common in the summer because people change their behaviors seasonally. So in the summer, people are spending more time outside, they're gardening, they're hiking, and there's just increased risk of exposure. We want to be able to rule out infections. And when we think about diagnostic techniques available, serology may be an option for infections like HSV, or if there are concerns about the lesions potentially being syphilis, RPR could be performed. But PCR might also be an option that's going to be really comprehensive because it's going to allow you to test for viral infections and potential bacterial infections as well. So really cover all of the pathogens most relevant to blistering lesions.
This is a great case because you have that element of clinical confusion. Is it pathogenic? Is it a non-pathogen? Is it an STI? Is it something from the environment? And urgency matters because I'm sure these people are concerned. So Dr. Goldberg, this was your case. Walk us through what you did for this patient.
The first thing I did was sit down and have a conversation with the couple. And you want to be respectful of your colleague who did the initial evaluation. Things could have clinically changed. There could have been different information conveyed. So I really wanted to start from scratch. And I wanted to interview the patient's history, understand any self-awareness of childhood infections, immunizations, recollection of an episode of chickenpox, a varicella infection, certainly past history of sexually transmitted disease. Had the couple, either of them, had a herpes genital infection in the past, and if either previously had a history of a shingles episode.
Thank you. Based off of that, we'll go to our next audience response question. In this scenario, would you have done STI testing? A, yes, for genital lesion pathogens. No, I'd only test for blistering lesions that are not classified as STIs. And so far we have a 50-50 split, kind of shifting back and forth. So we have about a 2/3, 1/3 split. Dr. Goldberg, what are your thoughts?
I think testing for genital lesion pathogens made sense. And at least in this couple and with this individual, I had high clinical confidence that we were not dealing with a HSV2 or genital herpes infection. And based on the clinical pattern, it appeared to be more likely a varicella virus or shingles infection. And because the patient still was within a narrow window of when an antiviral therapy could be helpful, we empirically prescribed vanciclovir at the appropriate dose for a shingles outbreak. One would follow up with, ideally, a next morning PCR result, or if not, in a little bit of delay, serology or other.
Janie, any other thoughts on this case?
I would just echo what Dr. Goldberg said, that if there's no genital involvement, it may not be necessary to test for genital lesion pathogens, but at the point that he had seen this patient where they had been empirically diagnosed with HSV2, it actually may give the patient relief that it's not HSV2. So being able to rule that out could be really comforting for the patient in this scenario.
Very good. Well, thank you all both for your insights today. Dr. Goldberg, any final thoughts that you want to share with our audience before we get to questions?
Well, 3 comments, Ben. It's always fun to have a microbiologist with you to offer the larger context when evaluating patients, but we don't have that opportunity regularly, right? So we've got humility about that. The second is infectious disease are a common problem in the urgent care setting. I see it regularly. I saw it yesterday in the clinic. And then finally, you really want to get it right, and getting it right involves knowing what types of infections you're more likely to see in the summer versus other time during the year.
Eliminating that clinical confusion and getting the patient comfortable with what you're doing seems like it's really important. Jenny, what about from a microbiologist perspective? Anything to close on?
People are generally really familiar with the seasonality of respiratory infections occurring at higher rates in the fall and winter. But there are also considerations for summertime infections because environmental changes like increased UV exposure causing higher rates of shingles episodes or increased temperature and humidity increasing fungal infection rates are common. And there can also be behavioral changes. People are going to go to community pools where there may be exposure to waterborne illnesses, or there may be increased exposure to environmental toxins like poison ivy. Thinking about the risk factors of different infections and the prevalence in the community will be helpful in diagnosing some of these summertime infections.
With that, we will end. Thank you for joining us for this Urgent Care Rounds brought to you by the Urgent Care Association Solutions webinar and Health Track RX.